All right, good morning, everybody. I figure we can get started. It's about 8:02. So welcome everyone to another session of High Rounds. Before we get started and I introduce the presenter, I wanted to have Dr. Wooten say a few words.
Good morning, everybody. I hope you all are staying cool as we're going through this heat wave. I just wanted to introduce a couple of ID fellowship applicants who are interviewing with us today. So a warm welcome to Christopher Kaparak, Matthew Capiello, and Jerica Werner. So good to see all of you. Thanks so much for being here and looking forward to speaking with you more in a little bit. Thanks, Marvin.
Thank you, Dr. Wooten. So I guess to get us started, sorry, we have some noise outside. I want to give a warm welcome to Professor María Zúñiga. She is a professor in the School of Social Work at San Diego State University and the campus director of the SDSU UCSD Joint Doctoral Program in Interdisciplinary Research on Substance Use. She holds a joint appointment as well at UC San Diego in the Department of Pediatrics and Medicine. She's a public health researcher with over 20 years of experience in community-based participatory research with communities impacted by migration and communities in the US-Mexico border region. She studies health disparities and healthcare access among vulnerable populations, including Latinx and other minority communities, populations who use substances, and those living with HIV. Her international research collaborations include ongoing work in Yucatan, Mexico, and Rio de Janeiro, Brazil. Throughout her academic career, she has cultivated expertise in creating and supporting academic and research climates and communities that nurture, at their core, diversity and inclusive excellence. Over the last 10 years, Dr. Zúñiga has mentored over 27 junior faculty, 19 of whom are underrepresented in health-related research, 43 PhD students, 23 of whom are underrepresented, and 7 postdoctoral fellows, 5 from underrepresented groups. Her own background as a Latinx faculty and researcher and over 20 years of experience as a mentor to underrepresented junior faculty gives her an in-depth understanding of how to lead system-level efforts to support diverse faculty in overcoming challenges that many underrepresented junior faculty face in their research and professional development. But thank you very much for being here, and go ahead and get started.
Good morning, colleagues. Thank you, Marvin, for that beautiful introduction. I'm sorry you all had to sit through it. It is, so my name is María Zúñiga, and it is such a privilege to be back with all of you. And I'm just, to be here at AVRC and someone who's had such deep roots with, and continues to have deep roots with UC San Diego, it is nothing less than a privilege to share with you a little bit of new work. So before I go into it, I don't know whether we want to, yeah, no worries. Oh, I'll let you. It's better to have a designated driver. No, that's fine. So the opportunity to share with you an area in which I am learning. I by no means am an expert in Brazilian healthcare, but I'm a learner. And I'm someone that is very passionate about the disparities that Brazil is facing in serving its populations living with HIV and promoting their continuity to care. And so I'll be talking about some of the intersections of racism, of social exclusion of Black Brazilians, and some of the opportunities for research that can help us improve the health of individuals living with HIV. So the objectives for the session are to talk a little bit about the policy context and comparison between HIV, Brazil's response to the HIV epidemic in the 80s and 90s, and their response to the COVID-19 epidemic. These are intertwined responses, and they're certainly distinct in the sense that there was a stark difference in how the Brazilian government responded to both of these epidemics. Talk about some of the lingering effects of policies and as Brazil recovers from COVID-19, and describe some of the challenges and opportunities for rolling out local community-based research. And I'll talk a little bit about a pilot study that is in process with, we're still in the pre-launch phase in an underserved community in Brazil. I also want to just acknowledge that I purposefully do not use the term favela. It is common and understood that it is a very underserved community, but it can also be pejorative. So I choose very carefully to use underserved, severely underserved, and economically marginalized and socially marginalized communities. So Brazil has a fantastic, on paper, healthcare system and a commitment to human rights. So the Sistema Único de Saúde, and by the way, I'm a learner of Portuguese, Spanish is my first language, is a fantastic approach to how Brazil delivers healthcare. There's a very complex network of care delivery from the centralized and municipality level healthcare organization and policies down to the local clinic level. And the universal, this particular system, the Sistema Único de Saúde, is based on the universal healthcare access, and that healthcare is a fundamental human right. So this was originated in the 1990s with precursors in the 80s, and you can start to think about the intersection between this universal approach to healthcare and response to the initial HIV epidemic. So Brazil had a very unique approach, and it was bred out of the approach to addressing the HIV epidemic. And much of it was rooted in the fact that they have an enormous infrastructure of scientific workforce. They have, at the time that HIV was starting to be detected, AIDS at the time, their system was built on collaboration, and that's why they have such a strong background and what they've offered globally as a model to understanding how access to care can work. And this is also with engagement of communities and interested parties affected by HIV. So just to give you a picture of the care cascade at this time, and this is pre-COVID, you can see here that the cascade of those individuals living with HIV, 936 are all of them, at least in this case, have been are people living with HIV. Then you have the diagnostics. 88% of the individuals living with those individuals are diagnosed. 82% connected with care, vinculados is connected with care. 74% retained in care, and 71% on antiretroviral treatment. And then with viral suppression, about 63% of those individuals who've been diagnosed are virally suppressed. So there's some work to do. The individuals who are primarily, so as in the US and elsewhere in the world, they're individuals, so the prevalence in the general population is 0.4%. The epidemic of HIV is concentrated in transgender women, where it's very high, 37%. In men who have sex with other men, 18%, female sex workers, 17%, and individuals who use crack cocaine, 5%. I want to underscore, as someone who's also a substance use researcher, that crack cocaine use in Brazil, they have the highest prevalence, mainly because they're also on a route that has, from Colombia and Bolivia, the cocaine flows and it goes through the ports and then out to East Africa. So as a consequence of being on a major drug trafficking route, there is a spillover of availability of very inexpensive crack cocaine, and that has devastated particularly marginalized populations. Although research shows that crack cocaine use and cocaine use among university students and other sectors of the population is also prevalent. So in 2020, the city of Rio de Janeiro had its 4th largest AIDS detection rate among pregnant women. So this is our next group of individuals, and the 4th highest mortality rate of all Brazilian capital states. So HIV in Rio de Janeiro. And again, it's a very huge metropolis, one of Brazil's largest cities. So this is where it's important for us to focus. We understand that individuals and socio-demographic determinants of health in the HIV care continuum, just pointing out that individuals with lower education, individuals, people of color, Black Africans, individuals with different mixed heritage are at higher risk because of their social exclusion, and is associated with worse health outcomes. And as I'd mentioned, that with this part is looking at gender-based discrimination, where transgender women are highly impacted by the virus. So to take the understanding of Brazil's response to HIV and the response to COVID and start to bring those together for us to what does that mean for health? What does it mean for research? There was an excellent article on which I'm basing part of this presentation that looked at what were the differences in terms of response. So as I'd mentioned, for the HIV epidemic, Brazil at the time, this was in the early 80s to mid 90s, Brazil had a very concerted response to the epidemic, to the extent that they themselves manufactured, they had the capacity to manufacture and make accessible antiretroviral treatment. And this is a historic piece that served as a model, because at the time, the pharmaceutical industries, and this has not changed much, had a stronghold on the production of antiretrovirals. So Brazil really was a groundbreaking country in terms of how it managed its epidemic. In addition, there was inclusion of communities that were impacted by HIV, caregivers, clinicians, researchers. And as I've mentioned, this comprehensive response helped Brazil manage and start to turn the tide on the early in the AIDS epidemic. So I'd like to give you an overview of what Brazil did in response to COVID. So COVID-19 public health response was undermined in very different fashion than HIV. It was undermined by government-fueled misinformation. You've probably heard in the media about Jair Bolsonaro, who's the current president, hopefully outgoing, and the misinformation that their government spread. They also had, in terms of even that vaccines don't work, they promoted chloroquinone, all sorts of non-evidence-based, in fact, the polar opposite, and social media campaigns. So there was a tremendous amount of misinformation. There was a lack of coordination between health entities, which is critical, and that very different from the HIV response, and dire inequities in access to healthcare. And again, we're talking about the exclusion of primarily people of color, and especially persons with African heritage, and ongoing violence. So I'll talk a little bit about the context of violence and how that's different in Brazil. US also has a very, where high violence in many ways affects the lives of US folks. In Brazil, it's a little bit different, and maybe a slightly exacerbated model of what the US has. So in terms of this is from Johns Hopkins Corona Resource Center, Brazil has, as of today, confirmed cases about 34 million. And so as the virus is circulating, it's same in the United States. You have more cases, more people are exposed, and also more people are vaccinated. 683,965 deaths were registered. This is probably an underestimation, as it is in other countries. In particular, Latin America, Mexico is very underrepresented in terms of understanding the true death impact of COVID-19. In terms of vaccine, to date, 471, say maybe 472 million doses have been given. I'm not fully familiar with all, but they use Sinovac as one of their, and also Johnson & Johnson is available. So they do have an array of the vaccines that have been available. Individuals who are fully vaccinated, as of this count, 171, maybe 172 million approximately. And that would translate to about 80.78%, 81% of the population is immunized. So with the lingering impact of COVID-19, it remains unclear how Brazil's most marginalized communities are able to access their HIV care and how local health clinics have responded to the needs of the community. And what I'm sharing with you is really the context in which we've developed our community-based participatory research pilot, and understanding that this work began before COVID-19 in terms of developing relationships with our colleagues and our counterparts in Rio de Janeiro, Brazil. As COVID was rolling out, and I'll share it with you, I mean, it was directly impacting to me. I was on sabbatical in Rio de Janeiro in January 2020. I was there and I had to come home in March. Just as the pandemic was rolling out, just as the uncertainty was there, I was in, I think, the last flight that came into LAX from Copa Airlines. So I really was vigilant in terms of how this was going to impact research in general, but also the lives of individuals living with HIV. So this is just a walk that I've been taking since that time. And I remain very engaged, and thankfully we have Zoom, we have WhatsApp. And so the continuation of research relationship then led to a successful application to the CFAR International Pilot Corps. So that's the acknowledgement of how we've been able to navigate this process. So just a picture of what we do know in the community context. Women living with HIV in Brazil, they have less access and lower adherence to antiretroviral therapy, lower viral load suppression than men, especially women with substance use disorder. So substance use is not far behind. And as I'd mentioned, much of it is related to crack use, and crack as a stimulant is something that can undermine completely how someone is able to take their medications. So that's an important part of our understanding of the community context. Women living with HIV in Rio de Janeiro's most impoverished communities are also exposed to armed violence on a daily basis. This undermines their ability to have an HIV, a continuum of care. So it's an environment that is exacerbated by police violence. I think it's very important to also understand the context of violence. So there are competing drug cartels, drug lords that have jurisdiction, I'll say, over different underserved communities and then in rich areas too. And then there is a police brutality and a police response that exacerbates the violence and ends in many innocent lives being lost. There's limited information about how women living with HIV in these highly marginalized communities are able to access the care that they need. And this is the backdrop for our study. We also know that there are barriers to HIV services, especially we are not sure about what kinds of linkages and outreach, because there are street outreach. There's an amazing network of clinical street outreach workers, but they haven't really tried a peer navigation model. And that was the impetus for our idea for this pilot study. So that, as you're probably familiar with, the peer navigation model is an evidence-based model promoting care engagement and adherence for the most vulnerable and people falling out of care. It has not been widely used in Brazil, and it's a critical opportunity to see how engagement of a peer may be able to support women as they look for care. So this pilot study is called Peer Navigation for HIV Care Continuity in an Impoverished Community, in a Brazilian community. And as I'd mentioned, we are at the baby steps and still formulating the process, waiting for NIH funding. And then we will roll with the IRB process and all of the wonderful things that accompany responsible conduct of research. this is our wonderful team. I want to acknowledge the PI of this study, Dr. Francisco Ignacio Bastos. I serve as co-investigator with Dr. Kiyomi Tsuyuki, who's my wonderful collaborator, and also just coming back from Brazil after an extended period of living there. Dr. Susan Keene, Dr. Lijani Toledo, who helped me put together some of these slides. Dr. Carolina Coutinho, also a co-investigator, and Dr. Bastos, Dr. Lijani, I don't know if this, yes, Dr. Bastos, Lijani, and Carolina Coutinho, and Dr. Alexandra Almeida are all based in Fiocruz, which is a premier research institute embedded next to the community that we are working with. So there's been a long-term relationship of Fiocruz, they have a health center, and their linkages with the Manguinhos community that I'll be speaking about in a moment. Mr. Daniel de Souza, and Daniel is a member of the community that we work with. You'll see his picture. He works with the health outreach teams, and he's someone that, so I've not Skype, we don't use Skype, we use Zoom. So we've Zoomed and had an opportunity also to build that bridge. I've invited Mr. De Souza to be also a panel speaker for a talk that I sponsored on social exclusion and marginalization in Brazil. And so we've started to build this relationship, even through so many miles of difference. And then I'd like to acknowledge Brooke Donabella. Brooke is a Master of Public Health student working with us and has been instrumental in helping us set up the protocols and survey questions. And so it's been a wonderful team to start this work. The study aims are to explore how substance use disorders and armed violence interfere in HIV care continuum and the opportunity for adherence of women living with HIV. And we will be applying the Christie's Place peer navigation model and interacting with community members, both community health workers and women living with HIV, to learn about their perspectives on applying a peer navigation model for outreach. So we'll apply this information once we've conducted this as a qualitative research study. And we will apply this to the integration of this peer navigation model and pilot test it. So this is what awaits us in this process. And just to give you an idea, as I'd mentioned, women are impacted both by women living with HIV, substance use and violence, increases social isolation, increase of substance use to cope, limited knowledge, skills, self-efficacy to achieve antiretroviral therapy adherence. And this is really based on the SAVA Syndemics framework, substance use, AIDS, and violence. So Christie's Place model is a mobile peer navigator model, and it works effectively when integrated with a healthcare delivery system. So we'll be looking for that to improve the adherence to antiretrovirals, the care continuity, and care engagement in women. A little bit about the context of where we'll be. So the community of Manguinhos is located in northwestern Brazil, within Rio de Janeiro proper. And it's a very well-established community. It has many years of being its informal community, but it's large, and it's been, it also has a presence in that they have self-developed ways to support the growth of children, the health of women. So I think it's an important thing. Many times as researchers, when we're working with underserved populations, we paint the picture so dire that that is the only impression with which you are left. So it's my job to make sure you see some of the positive as well. In terms of violence, there is ongoing context of violence. This happened very recently, the Jacaranzinho massacre in Rio de Janeiro, 28 people were killed. There was a police intervention. And this is the type of violence that individuals in Brazil, especially in marginalized communities, face on a daily basis. And of course, it has a mental health toll and a coping toll as well, particularly for Black Brazilians. So this happened in, this was in 2020. I think it just happened. What's the date on here? It just happened less than a year ago. So these are the types of things that allow us to continue understanding the context. So it's a as I'd mentioned, neighborhood in northern Rio de Janeiro. It's got 12, it's an enormous area, about 43,000 people and 10,800 households, just to give you an idea of magnitude. And one thing I think is helpful to see is Fiocruz, our partner institution, is very close. Again, it's in the Manguinhos region itself. So the Manguinhos community suffers from high poverty levels, health inequities, HIV and substance use, and many of the things that we've talked about. It's the 5th worst human development index in Rio de Janeiro. So it absolutely has it's an underserved area if we haven't put that in it. Just a few pictures to really show the level of need and outreach that occurs. So the colleague in the mask is also a member of our research team and was dispatched in serving individuals who are living with HIV and not being able to come in for care. So this is an example of the outreach. We'll be working with the Clínica Victor Valla in Manguinhos. And the clinic, this is just an example of the daily violence and the impact. So during the COVID-19 pandemic, the violence in Rio also impacted. So if you can imagine, services are already being impacted by individuals, lack of healthcare workers, healthcare workers who themselves suffered, got ill, their family members died. Violence was present in also curtailing the ability of the clinics to offer services. So despite being an underserved region, this is where I want to focus. What are the aspects of the community that favor their resilience and their celebration of self-identity? So it's home to a vibrant and resilient community. They do have a system of promotores. This is an example of one of the samba schools. That flag is from a samba school. You may be familiar with, the carnaval events and the parades and the samba schools. So they are home to one of the samba schools. There is also important work being done in educating the children, providing proper education. There's social consciousness and really, I think, more ability to promote integration of all people within the community than we see in many other places. So tolerance, inclusion, and diversity. These are just some shots of the work that the outreach team has done with some of the most marginalized. These are probably these are individuals who are probably without homes or without houses, unhoused. During the pandemic, this is the health outreach team, and this is Danielle, one of our colleagues. So the population that we'll be working with are women living with HIV. Their self-identity as a woman, so transgendered women are absolutely welcome. Self-reporting, someone living with HIV, alcohol or substance use, and that they are cognitively able to provide informed consent. The community health workers, we will be interviewing 20 community health workers in Manguinhos, individuals who work at one of the primary healthcare centers, and that they are directly involved with HIV treatment and have access to resources for participating in video conferences. So this work, the pandemic's still going. We may be able to get permission to do some in-person interviews, but we are prepared to do fully virtual interviews as needed. So I bring to this next part of our time together, I want to create an awareness that research and our obligation as researchers involves understanding the deep inequities and the social exclusion of Black women particularly. This is a picture of Marielle Franco, and Marielle was a sociologist, a feminist, and a human rights. And I talk about the past because she was killed in 2018. There were two people that were eventually arrested, but there is very much understanding that because of her position and her influence, she was a menace to different members of the government. So she was returning from an event encouraging Black women's empowerment in Central Rio and was gunned down on March 2018. I just want to say a moment that it is not lost on us as researchers, and Marielle Franco's death remains present as we roll out our research study. This is a beautiful mural, a homage to her at San Diego State University, where we have a program on Brazilian studies. I think it's important to acknowledge researcher positionality when we're working with underserved communities, especially communities living with HIV and communities who are impacted by substance use. In terms of our limited understanding as researchers and how we really have to come into the research with an advanced level of cultural humility in order to be able to do the work properly and be effective and develop something with the community that will be useful to the community. And our obligation is to conduct work in all aspects purposefully and with consciousness and responsiveness to the inequities that we will be observing in our work, especially the social exclusion of Black women. So Marielle Franco was one of the first Black women in the Congress or in the municipality. She was somebody who was a council representative. Very rare to see someone at that level in government. And it is also, as researchers, our job to be committed to racial justice and better health, in this case, for Black women in Brazil. So I want to acknowledge that this work would not have been possible, at least this start, without the Center for AIDS Research Studies, the Center for, and as well the Center for Brazilian Studies at San Diego State University. They provided 2 years of seed funding before we got this work going. Any of you who are familiar with community-based research know that it takes a long time. It doesn't happen overnight, and it takes commitment to sustain relationships. So this is our opportunity to really continue to build relationships, build trust with our colleagues, and really know that the leadership for the research is coming from Brazil. It's not coming from the US. So thank you very much.
Thank you very much, Dr. Zúñiga. That was really, I think, impactful. I have to say, obviously, your passion for Brazil and the communities there is very apparent. And I really liked what you said, that now we sometimes focus too much on the negatives of the communities and what they're really facing, but it was really nice to see that you also highlight the beauty and the joy that's, you know, the power and the impact that these communities can have and do have, not just why they're underserved. So
thank you. I'd like to, if I may,
Yeah.
just add something. This is the reason that research, where we look for the negative because we look for something that there's a gap, and we want to, in all good commitment to the science, make sure that we are addressing those gaps. When we do that, we show the worst part of who we're working with. And I think that, in my opinion, is driven very much by the way that NIH is formulated, the way that we respond to calls for proposals, the way that we write our research proposals. And it's an area that I'm very interested in, because the more we convey to others that there's a group of people that are just in such need, that perpetuates, in many ways, it can perpetuate either a misunderstanding or a very limited understanding of the populations that we want to serve. So I very much encourage us in our publications, which is one way, the way we deliver care, publications, the way we convey our science, to give light as much as possible to the communities themselves and what they themselves have, as Marvin was talking about, in terms of beauty and resilience.
I see a comment from Dr. Aldous, so I don't know if you'd like to unmute yourself and speak to it, please.
Sure. Hi, Marty. It's so great to see you.
Hi,
I always love to hear your talks because it opens my mind to something new every time. And this was a very interesting talk. I had heard a little bit in the past from you about your work in Brazil, but the aims, when it specifically listed gun violence in your aims, that really caught my eye. And I realized, I don't think we have, communities in this country that face daily risk of gun violence, communities that face risk of police violence. And I realized that I hadn't really seen much on the impact of risk of gun violence and on the HIV epidemic in the US. And then I realized probably I haven't been looking. So I was curious if you had any comments on that, or if this research has brought up any eye-opening thoughts about communities that are impacted by HIV in the US.
Thank you, Dr. Aldous. Actually, I don't have that. I'm in the same boat as you. I think I need to learn more about it. I've been focusing my efforts on understanding the context in Brazil, the context in the US. There's so many parallels. And so I agree 100% that there needs to be some understanding how police violence within marginalized communities in the US. I mean, if we can think about, as an example, or even responses to how marginalized communities are treated, the clearing of a encampment of people without housing. Those are the types of things that I think we should maybe consider in terms of how violence, not necessarily gun violence and other types of violence and acts, can undermine people's potential for continuity of care and care engagement. And I do believe that the model, and Brazil has an amazing model of street outreach, like clinical teams, a physician, a nurse, a social worker. So I think that type of model is something, and we have used it to some extent in the US in very limited capacities. If we can start to think about that type of model for reaching individuals who are so marginalized. Now, in terms of the gun violence, I absolutely don't have a response for that because the US is so armed. I mean, it's not in Brazil, we're talking, it's not common for your average household to have a gun, a handgun. It's a very different context. You have armed individuals who are working in drug trafficking and police, obviously police violence. We didn't even touch on incarceration. Incarceration in Brazil is very parallel to the US. Predominantly individuals who are poor, individuals who are of African ancestry, individuals who have substance use disorders in the criminal justice system. So again, I think I appreciate your comment because there are so many parallels, and I do need to learn more about the impact of violence on seeking care in the US. So that'll be my next area to look at. And I appreciate, Dr. Aldous, that you brought that to my attention.
Well, I think it should be to all of our attention because it's actually something I've not, I've been in this field kind of a long time now. And I do think about a lot of disparities and psychosocial factors that impact access to care, and certainly violence against women and trust of the system and things like that. But, specifically, gun violence, armed violence, and that epidemic overlapping with the HIV epidemic is something I haven't really heard much discussion about. So I think it's interesting.
Thank you very much.
I see Dr. Borquez has her hand up. So if you'd like to unmute yourself.
Thank you, Marvin, and thank you, Dr. Zúñiga. That was so interesting. And yes, as Annette was saying, makes us think. I just wanted to follow up on the conversation you both were having about the impact of police violence on the HIV epidemic. As far as I've seen, it's mostly focused on police violence, on HIV risk among people who use drugs, because the pathways are much clearer in terms of confiscating syringes, in terms of like incarcerating people if they're injecting outside. And so, I mean, there's like a huge field of research in terms of the impact of police harassment and police violence on risk of HIV among people who use drugs. But I agree that I haven't seen it in the context of Black communities in the US. And as you were saying, I think it's going to be very hard to disentangle the effect of police violence and of incarceration on HIV risk. But it would be really interesting. And it also reminded me of something else related to violence, not necessarily police violence, but violence in general among people who inject drugs in Tijuana, where it's something that we haven't investigated as much. And I mean, we know that the risk of dying by homicide among people who inject drugs in Tijuana is huge. And in a way, HIV becomes a lower priority compared to the risk of imminent death through violence. And I think it's partly because because we don't feel able as public health researchers to address that problem, cartel violence, and it feels like something that's beyond public health. And I actually think that it's not actually out of the reach of public health, because if people were given more access to treatment for opioid use disorders, they would be less exposed to this violence, and studying these interactions and these effects would be really interesting.
Thank you very much, Dr. Borges.
No, thank you. But that was just a follow-up. I actually had a question for you in terms of, so you were speaking about the exceptional healthcare system in Peru. And I also know that there's a unique kind of healthcare system focused on HIV care delivery, and a separate healthcare system, I shouldn't say healthcare system, but component of the healthcare system that's focused on substance use disorders. Yes. But my understanding is that they are not very well integrated. And given that your research is very much looking at the integration of these, well, at the syndemic aspect of substance use, HIV and violence, I was just wondering how you had considered this lack of integration in the research.
Thank you very much. That is actually one of the things that we will be asking the community health workers and the women living with HIV to understand their opportunities. So having been in a couple different clinic environments in Rio de Janeiro, and I was actually in in a different underserved community, and I had quite an extensive clinic that offered, again, I think we also need to understand what are the treatment possibilities that are able to be offered for persons living with a substance use disorder. And I think that remains to be seen. There is absolutely fragmentation. There's no doubt about it. And that was exacerbated in the COVID-19. So in COVID-19 pandemic. So to be able to understand more on the ground, more comprehensively, what the experiences, the treatment experiences have been for those women who have sought treatment. And for those women with a substance use disorder, why haven't, for those who haven't sought treatment. So I appreciate very much your insight on that, because it's an area that we need to understand more broadly. And also, I think in my next presentation, I would give that context of the siloed treatment, and very much, again, parallel to in many places in the US, how mental health services and HIV services and substance use treatment can be disconnected. Thank you very much for bringing that light.
Thank you.
Do we have any other questions or comments? I see there's a couple of things in the chat. I don't know, Nicole, if you wanted to say anything, but she mentioned the questions that Dr. Aldis brought up about gun research in the US. She just made a comment saying the Dickey Amendment restricted so much gun control research since 1995 in the US, which is why federal funding has not been available to ask the kind of questions that you were discussing.
Thank you. Thank you very much. And I would also like to add that the political situation right now in the United States, where certain states are elevating access to handguns and promoting gun ownership is certainly not helping in terms of our ability to progress in understanding what will be the impact of violence on access to care generally and HIV care specifically. So thank you very much. Was that Dr. Nicole Pepper?
It was Nicole Carter.
Oh,
that made that
Carter.
comment.
Okay. Thank you, Dr. Carter.
Does anyone else have any questions, comments? Yep. Sandra?
Thank you. This is an amazing presentation. I just want to mention,
Thank you.
I got an opportunity to I used to work with family health centers, and I was a peer navigator there. And I got the opportunity to work at the syringe exchange, where they also started a program where this was for hepatitis C. And they had a mobile unit next to the syringe exchange, and I would be testing anybody that wanted to test that was there, getting their syringes and all that. But it was pretty new to see and exciting how it was working, because they were randomizing people to it was a pilot research that they were doing, and but people were getting treated for hepatitis C in the mobile unit. There was a doctor there that was seeing them, giving them their medication. They were still working on trying to get, like, maybe holding their medication so they can just, they had somewhere to have their medication. But it was a working, progress. But just having to have a hand, being there was very exciting. And just going back, this took me back. And it was at nighttime. A lot of people were very thankful. These were some of the needs that they needed. They don't have where to sleep. They're out in the street, but the help comes to them. And somehow it was able for them to, okay, they will also get Suboxone treatment. So a lot of them started, like, getting back on their feet. Yeah, we had some that would go back, but we could see the difference. And it was an amazing experience, and just seeing this presentation just took me back. And I think this is something that needs to be more of work, I think, out in the field, everywhere. But I think that I'm glad this is going out to other places now. So I just want to thank you for this.
Thank you so
you're
much.
welcome.
Very much appreciate your comment, because the opportunity to see how a peer navigation model could be translated in another context, we might learn something that can then come back and inform the work that we do here in the States. So I think that's one opportunity. I'm very much a proponent. You've got to keep the learning both ways, and there's always opportunities. And so also we'll be learning more about how the effectiveness of the street outreach team, and really understanding that model as well. So again, this is a beautiful opportunity. It's a baby step as a pilot study, but it can lead to better understanding of how to reduce barriers, right? That's what you're talking about, is your, very low threshold barriers for people living with HIV and individuals living with a substance use disorder. So thank you so much for your comment.
Dr. Borquez, I see you have your hand up again.
Yes, I'm making the most of the 10 minutes left. I was just wondering if Dr. Zúñiga could give any examples of the strategies that the public healthcare teams, the community public healthcare teams, have used so far to deal with gun violence, or if that's something that you're going to be collecting as part of the research, and there's not that much information available yet.
I'm happy to share my very limited experience. I was invited to go to the field of to the community during my time when I was on sabbatical in Brazil. And this was an opportunity to see how the public health system was working in a particular community, meet some of the outreach teams. And the day I was supposed to go, it was canceled because of police violence. So I can just only imagine that if my very limited opportunity to be an observer and listener in a context that's impacted by violence, that's the level of impact. So I can only imagine the community themselves. So I appreciate your, you know, and we will, because we're working closely with the communities, outreach workers will be already, this is the work that they are engaged with in terms of understanding that people don't go out of their houses. And these are interruptions in how you access care. But to our knowledge, it hasn't been systematically documented. So this is where we're going. And I really appreciate your thoughtful question about this, because it has, this is part of the talk, really. It has an impact on how our capacity to conduct community-based research. Thank you.
Thank you.
Do you have any other comments or questions? Okay. Well, Dr. Zúñiga, thank you so much for coming in and giving this fabulous talk. And thank you everyone that's been online. So I guess we'll conclude today's session. So we'll give a round of applause again for
Thank
Dr.
you
Zúñiga.
very much. Thank you. Thank you
All right,
for
thank
the
everyone.
invitation.
Thank you so much. All right, everyone, have a great weekend.
Have a great day.